Hey guys, today I will be talking about the pathophysiology of asthma. So this lecture will actually include the definition of asthma, the classification of asthma, as well as the pathophysiology of asthma itself, which has two phases. So we will go and talk about it later on. So let us get started with the definition of asthma first. So what is asthma? Asthma is defined as intermittent, possibly allergic inflammation of the airways, which is accompanied by wheezing, cough, breathlessness, and chest tightening, mostly during night or early morning. Basically, it is an obstructive disease, which means the problem is when you are trying to exhale, which is actually quite similar to emphysema as well as chronic bronchitis. So all these diseases are actually chronic. So at the same time, they are also different from COPD. How? So asthma is mostly reversible. That is, when you administer drugs and you can actually bring the airway back towards its normal condition. Whereas for COPD, like chronic bronchitis and emphysema, they are usually irreversible. But we can actually give drugs and do some intervention to stall or reduce the progress. In asthma, what you must know is there is actually a triad of events in asthma. That is a triad of events of pathogenesis of asthma. So the first one is airway obstruction, followed by smooth muscle hyperplasia with hyperactivity, which eventually causes bronchospasm, and the third one is inflammation, which is the final process obviously. So as I said just now, asthma is intermittent. So asthma actually can be phasic. That is, the first phase usually would be a immediate allergic reaction, then you eventually become okay, followed by a reaction which is usually a few hours later. The patient usually might have bigger attacks which last longer. This is the reason why asthma is classified as intermittent. So now we are going to discuss about the types of asthma. So basically there are two types of asthma. The first one is atopic, which is extrinsic, and the second one is non-atopic, which is intrinsic. Atopic basically means there is a predisposition towards hyperreaction to normal allergen. Usually 80% of the people can tolerate this, but those 20% of people who has this genetic predisposition, they usually can't tolerate this and eventually show hyperreaction. So these patients usually will have a familial inherited disposition towards reacting to normal allergen. So basically what these patients would have is they would actually have an increased amount of Th2 cells. So why we call it as extrinsic? Because they must be exposed to something externally, such as dust, drug, cat, or pollen or something. So whereas for non-atopic or intrinsic, they means they are non-allergenic. There is nothing from outside can cause it, but from there is something inside which is actually causing the asthma attack. For example, drug related such as aspirin, exercise, stress, cold, or so on and so forth. So the patient is usually not hyperallergenic. So now before I go to the pathophysiology of the asthma, I believe all of you should know the histology of the respiratory tract first, because if you don't know the histology of the respiratory tract, you wouldn't be understanding this diagram in front here. So when you see here, I've drawn this pseudo-stratified ciliated columna as well as this smooth muscle at the same time. So from this you can know that asthma usually attacks the intrapulmonary bronchus. Okay, so now let me just explain this diagram first. So here you can actually see this mast cell outside the epithelium, and this is actually the mucus. This is actually the pollen. I forgot to label that. And this pollen is actually being taken up by the dendritic cell. Later I'll be explaining about this. And this is the basement membrane, lamina propria. This is actually the vagus efferent, which is actually the subepithelial location. And vagus efferent sends message, and the response is coming back through the vagus efferent, innervating the smooth muscle here with the neurotransmitter acetylcholine. We also have this B2 receptor. Later I'll be talking about this also. And okay, from here to here is actually the mucosa, which is basically epithelial plus basement membrane. And this is actually smooth muscle layer. Remember, smooth muscle layer is not part of mucosa or submucosa. They are just them by itself. And this submucosa is basically the glandular layer, where you will actually be having this seromucous gland. So now I'll be talking about the location a bit more further. Location of the things here a bit more further. Okay, under the epithelium we have this vagus subepithelial receptors, which are actually efferent. That means they take the signals away from the respiratory airway to the center and bring the efferent back. The vagus efferent release acetylcholine onto the bronchial muscle, which is here, which causes the contraction of the smooth muscle here. So this is why it is actually causing the narrowing of the airway. If you can block the release of this acetylcholine, you can cause the dilatation of the airway. And then now we are going to talk about this beta 2 receptor. Respiratory airway don't have a lot of sympathetic innervation. However, they do have beta 2 receptor present on the smooth muscle. And when these receptors are stimulated, let's say you actually have adrenaline or noradrenaline to stimulate this beta 2 receptor, this smooth muscle will actually relax. That is why in treatment of asthma, which we will usually start with the short acting beta agonist, which is also known as SABA. So you can also give acetylcholine blocker here to remove parasympathetic effect, which usually cause constriction. However, this will produce a lot of side effects, because we know antimuscarinic actually can produce a lot of side effects. Okay, so that's why it is always better to use beta agonists. So okay, now we are going to talk about the pathogenesis of the asthma. Okay, let's say first the patient is allergic to some pollen. Okay, this is the pollen. That pollen comes and gets trapped by the dendritic cell, where the dendritic cell is going to eat up the part of the antigen and digest them and send them inside into the lamina propria. So inside the lamina propria, the remnants of the antigen are going to be picked up by the T cell receptor as well as the B cell. The B cell will then process it and present it outside. Remember, B cell is actually APC, antigen presenting cell. That's why it actually can present it outside, and that will form a CD14 ligand interaction. When this interaction occurs, this will eventually cause enable the Th2 cells to release IL4 as well as IL5, interleukin 4 as well as interleukin 5. So what happens is, this interleukin 4 will eventually go and bind to the interleukin 4 receptor onto the B cell, and now we will cause some reaction onto this B cell. So this B cell will eventually get activated and proliferate into what we call as plasma cell. So these plasma cells are the one which I didn't draw it here, but yeah, this B cell will turn out to be a plasma cell, and these plasma cells are the one for which will eventually release immunoglobulin. So under the influence of this IL4, it causes the class switching, which cause change in production from IgM to IgG and eventually IgE. Okay, so the plasma cell will eventually produce IgE due to the class switching that is triggered by this IL4. So this IgE will eventually start to load on the mast cell. If you see here, it is getting load on the mast cell by binding to Fc epsilon R1 and R2. Okay, if you see here, this or you can just call it as a Fc receptor. This Ig is actually being bound to Fc receptor in the lamina propria as well in the epithelium. Okay, so I want to just mention here that mast cell is not specific to one kind of antigen or allergen. Reason is because they acquire IgE, that is, they don't produce IgE. IgE is being produced by the B cell, but they are actually acquiring it by binding onto the Fc receptor. That means it only has to have this receptor. So many, like one mast cell can actually have many IgE, such as IgE against pollen, IgE against egg, IgE against seafood. All these IgE actually can bind to this Fc receptor. So that means one mast cell has the capability to respond to more than one kind of allergen or antigen. So all these things which I have mentioned here is the events that occur when the patient is not having any symptoms. So now we are going to that means during the first exposure to this pollen. So now we are going to talk about the events which occur when the patient is having exposure to the subsequent exposure to this pollen. Okay, during the subsequent exposure, what happens is pollen comes again during second exposure. Okay, then IgE. Okay, you see here, IgE. What will eventually happen is the IgE will become stuck onto the mast cell. Let me just rephrase this once again. Okay, what happens here is the IgE is now being cross-linked by the pollen. Okay, the pollen will actually go and cross-link with the IgE and eventually cause the IgE to degranulate. Okay, just now you have this mast cell, but you don't have this IgE. So pollen comes also, it cannot bind onto this IgE. But right now you already have this IgE. So when the new pollen comes in, during subsequent exposure, what happens is this pollen will go and bind into this IgE and eventually cause this mast cell to actually degranulate. Remember, at this time, this pollen cannot go inside yet because the epithelial cells are still intact. So it will actually attack the one in the epithelium first, mast cell in the epithelium first. So eventually, these mast cells will actually degranulate. So what happens when actually it degranulates? The mast cell will eventually release their mediators such as prostaglandin, leukotriene, interleukin, histamine, and so on and so forth. All these inflammatory cytokines will allow the gap between each epithelium cell to further open, and eventually from this gap, now the antigen or the pollen actually can go inside. Okay. Just now the epithelium was intact, so the pollen cannot go. So now it already has activated this mast cell. Mast cell releases inflammatory cytokine, causes the epithelium gap to be wider. So now this pollen actually can come inside into the lamina propria. So what happens when the pollen comes into the lamina propria? So this pollen now will actually go and bind onto this subepithelial vagus efferent receptor. This vagus efferent would bring the message back to its center, and there will be a local and central reflex there. And the vagus efferent will eventually become activated, which leads to the bronchial constriction. Okay, so this is called as smooth muscle reaction through nervous system by direct activity of the antigen, which just now I mentioned it is also part of the triad of events during the pathophysiology of asthma. Next, what happens is the mast cell also send some this mast cell also sends some chemo attraction in order to attack neutrophils and eosinophils into this lamina propria. So remember that the primary player in asthma is always eosinophil. Okay. So after it calls, that is the role of mast cell. Just now we have mentioned the role of mast cell to activate the vagus afferent. Then we also have mentioned the role of mast cell to act as a chemo attraction. Now we also can another function of mast cell is it will also produce the leukotrienes C4, D4 and E4, and these leukotrienes will actually cause bronchoconstriction as it acts on the smooth muscle. It also will actually act on the blood vessel in the lamina propria. I forgot to draw here. So, and when these blood vessels dilate, more fluid will comes out and it will eventually cause edema. And this edema will eventually cause the wall to swell up and airway passage shape will eventually become narrow. And it will eventually, this leukotriene also can cause the seromucous gland to become hyperactive, which eventually produce a lot of mucus, which goes to and sits on the surface epithelium. And when there is a lot of mucus here, eventually it can also cause the narrowing of the airway passage. So that is the role of mast cell in producing leukotriene. Mast cell also produce another one thing, that is prostaglandin, which causes bronchoconstriction, bronchoconstriction as well as mucus secretion. But it does not act. Remember, prostaglandin does not act on the blood vessel. It only acts on the bronchoconstriction on the smooth muscle as well as seromucous gland. Okay, so that is those. Okay, just now we mentioned that asthma usually have two phases. One is immediate reaction, another one is late phase reaction, which is more serious. Okay, just now which I have mentioned before, all the events which I have mentioned before, all those reactions are the one which actually occur during the first phase, which means that when there is no such serious effect where the patient will eventually becomes okay. Now I'm going to talk about the late reaction to allergen. That means after a few hours, which lasts longer, more than 12 hours to 24 hours. So during this reaction, the patient don't have to be exposed to antigen anymore. For this phase to start, they are usually caused solely by immediate reaction. So just now we mentioned here Th2, they release IL4 and IL5. But remember, just now I have only talked about the role of IL4. IL5 is the main key player in the late phase reaction. So this IL5, what it will cause is IL5 is secreted by the Th2 cell and mast cell. Okay, and eventually it will actually activate eosinophil, which I didn't draw here. So eosinophil will eventually release two substances, which is major basic protein as well as cationic protein. These two proteins will go up to the respiratory epithelium and become the destructor of that epithelium. And the epithelial damage starts and eventually cause the inflammation to start. Eosinophil also secrete inflammatory substance that will do the same thing as leukotriene, that is increased vascular dilatation, increased mucus secretion as well as bronchoconstriction. So all these events which I have talked right now is the events which will actually occur in an atopic type of asthma, that is when the patient is actually having a genetic predisposition and having a lot of Th2 cells. Okay, there is also another type which is due to drug. Okay, just now what drug I have mentioned? I have mentioned about the aspirin. So now we are going to talk about aspirin as a trigger for non-atopic asthma. So aspirin, what it does is aspirin blocks cyclooxygenase pathway. When the cyclooxygenase pathway is blocked, the prostaglandin production will get reduced. However, lipooxygenase pathway will become imbalanced and become triggered, and now leukotrienes can become activated. When leukotrienes are produced, it will eventually cause all the events which I have talked about just now: vascular dilatation, smooth muscle constriction, as well as mucus secretion, and eventually cause the airway to become constricted. Asthma attack will eventually occur. So that's all for this lecture. If you like this lecture, do like and subscribe to my video channel. Thank you.